to Med Echo for today, May the 12th of 2020. Hope everyone is staying safe and healthy. Again, I'm Snehal Bhatt, the Chief of Addiction Psychiatry here at the University of New Mexico. And gonna do some, and again, even as I start out, no disclosures, no financial disclosures, either in the past or in the present, regarding the content of this activity. So we're gonna do some basics of opioid use disorders and pain, which is a topic that comes up a lot. And a topic where, we're learning a lot of new things even in the last 2-3 years, and how we manage this sort of pain in individuals with opioid use disorders has shifted tremendously. So I think my goal here over the next 20-25 minutes is just to provide the basics of it. So what are we gonna do? We're gonna describe and understand the clinical importance, it should say, and utility, and let me move this out of the way, of comorbidity of opioid use disorders and pain, understand how opioid replacement therapies do not preclude the need for effective pain management, and finally describe and apply strategies to manage pain in patients on opioid replacement therapies. So I'm gonna start just a little bit with prevalence. So how common is pain in individuals with opioid use disorder? And this is sort of, I tried to compile some of the studies, going back to the Rosenblum study but from back in 2003, which showed that about 37% of individuals with opioid use disorder also had chronic pain. But if you look at some of the more recent studies, that number is higher. The SARE study from 2017, for example, pegs it at almost 2/3, or that study reported that about 64% of individuals who came in seeking treatment for opioid use disorder in that particular study had chronic pain. So that was a good study. So I kind of looked at it further in terms of breaking it down in terms of what comes first, right? Generally, the relationship is accepted to be bidirectional. However, again, in this large, this large study of over 5,000 individuals, adults with opioid use disorders coming into treatment over a 10-year period, right? Again, about a third had no pain. Another 2/3 had met chronic pain criteria at some point or another. So then if you look at it further, right, for for most of them, so about 40% of individuals, it was the pain that came first. So it seemed like the chronic pain initiated first, and then the opioid use disorder developed at some point in their history. For another 15%, both were present. Kind of at the same time, and it was unclear to determine. And for about 10%, it was the opioid use disorder that came first, followed by pain. Perhaps not surprisingly, patients who started with chronic pain, who had chronic pain first and then developed an opioid use disorder, which is about 40% of the population of that sample, had high rates of other mental illnesses as well as other health conditions. On the other hand, the patients who had opioid use disorder first, before the onset of pain, were also more likely to have other substance use disorders, as well as things that may be associated with that use disorder, such as HIV and hepatitis C, right? But they were the minority compared to the people in whom the chronic pain came in first. So I wanna, so just with that idea that it's not uncommon, that's the take-home point I wanna give, that if you're working with a patient who's coming in seeking treatment for opioid use disorder, very important to ask about any history of chronic pain, because it's not uncommon that the person will have chronic pain. And as you'll see, that might impact our treatment choice. On the other hand, if you're working with an individual with chronic pain, then I think there are all these risk mitigation strategies we can put into effect to minimize the likelihood that the patient will in the future go on to develop opioid use disorder. We do a whole other echo session on that, on responsible opioid prescribing. Right, so that's not the focus of this talk, but I do want to give that introduction. So let's start with acute pain management. I pulled some sort of art that I just found online, done by individuals living with pain, which I thought was kind of poignant. And this is one of them, and this one is called Overwhelm. Done about 6 years ago. This is an individual who made this public. So a vignette. AN is a 45-year-old female, status post-shoulder surgery. History of opioid use disorder, and was previously treated with methadone on 2 different occasions for opioid use disorder. But both times she stopped treatment and relapsed and returned to using illicit opioids. Right before the surgery, she had been using about half a gram of heroin 2 to 3 times a day, smoked. She is also on now post-surgically, she's on morphine, continuous infusion, 4.2 milligrams per hour. And then in addition, she's allowed to get a 10 milligram IV bolus every 4 hours for breakthrough pain. And she last used it 2 hours ago. She's requesting more pain medication. She reports that her pain is 9 out of 10. She's in tears. Her vital signs are stable. Her pulse is not elevated. Her blood pressure is not elevated. And when you get to the unit as the consulting provider, you hear the patient is drug seeking. She's already getting more pain medications than any other patient on the unit. She doesn't need more. Besides, she's an addict, and we don't want to worsen her addiction, right? So let's start with that. And we've got, okay, I think it's people. Just want to make sure there are no questions. Going through it. So what do you do? So we're going to start with some commonly held belief. In general, from what we understand, acute pain is frequently undertreated, whether there's a history of substance use disorders or not. A couple of studies actually say that in about 60% of instances in inpatient settings, acute pain is undertreated. So not uncommon. And this might be even more so in patients with addictions with substance use disorders. Although we don't have great data on it, there is sort of expert consensus that this is even more likely to happen. Because we do know that individuals with substance use disorders are viewed by healthcare professionals in sort of a negative light. So addiction, according to Morgan, is seen primarily as a social problem that requires law enforcement rather than a health problem that requires prevention and treatment. And because of this perceived controllability, there's this idea of blame upon the individual who has a substance use disorder. It's also been shown that healthcare providers will often view individuals with substance use disorders as being manipulated. And on the other hand, what we know is that the person with a substance use disorder who's in the hospital, their biggest fear is that their pain will be undertreated, right? So there's a big gap between the two sides that we hopefully as providers have to try to bridge by being advocates for our patients in a safe and effective way. So caveat here, a lot of this research, a lot of this work has been done in a nursing literature. So I know here it's talking about sort of prejudice and in a nursing standpoint, from a nursing standpoint, but that's not because, I'm trying to sort of single out nurses. If anything, it's amazing that the nursing literature has actually delved into this in more depth, right? So it may be that the nursing literature is just ahead in terms of recognizing the utility of appropriately treating pain in individuals with opioid use disorder. So what this is really getting at is sort of a paradigm of often what happens, where of course we're in the midst of the opioid epidemic. This is a problem that's affecting our communities, our families, our friends. There's a lot of media attention. There may also be this stigma that's often emphasized. Studies have shown even through healthcare training, right? So there may be the stigma playing into it. Prior negative experiences. Oftentimes our individuals with opioid use disorders can be challenging to work with. So there might be prior negative influences and lack of formal training. In general, it's been shown that in professional schools, in professional education, education geared towards pain management and substance use disorders is woefully minimal, right? So that all of those factors then come together to lead to misconceptions, which may lead to under-medication of patients experiencing acute pain perioperative, and then which leads to, of course, unrelieved pain, which in turn has been associated with a number of adverse outcomes, including chronic pain, depression, anxiety, social isolation, poor health outcomes, as well as future mistrust of healthcare systems, something we certainly see at ASAP a lot with our patients coming in. So what is the suggested approach to avoid that? So first of all, accept the patient's self-reported pain, right? It's been shown that pain behaviors vary widely. There may be a cultural element, a gender element, or as well as an individual element to how people express their pain. And vital signs are not extremely reliable. They're not very reliable indicators of pain intensity. So I think we have to start with a position of we're going to believe our patient. One of my mentors when I was in residency said that, well, if you're not going to believe your patient, who are you going to believe? And I think that sort of stayed with me. Consider whether there is an addiction or whether it's a pseudo-addiction versus physiologic dependence. Quick definition: physiologic dependence simply means that a person has become used to a particular medication. Can happen with many of our medications, including, for example, stimulant laxatives, where if a person has taken a medication chronically, their body is used to it, and if they stop suddenly, they might have withdrawal symptoms. Does not classify addiction, right? Does not mean a substance use disorder, which has all these other components such as compulsive use, adverse consequences, continued use despite those consequences, right? As well as cravings are all part of the addiction or a substance use disorder. Pseudo-addiction is a term that's really been around since the 80s. And what it really means is that a person's behaviors might on the surface seem like they've developed a substance use disorder, but in fact, what's happening is that they're just not receiving enough medication. So in other words, they're pressing that button, calling the nurse, asking for more medications, simply because they're not receiving enough medications and their pain is actually undertreated, right? One of the classic ways of differentiating between addiction and pseudo-addiction is what happens when you actually go up on the dose. If it's a pseudo-addiction, as you go up on the dose of the pain medication, their functioning should improve. On the other hand, once that substance use disorder has set in, even if you go up on the dose of the medication, certainly their functioning will not improve, but may in fact continue to worsen further. And if required, it's been recommended that you do not withhold opioid analgesics from individuals with addictions, with substance use disorders. There is in fact no data showing that acute pain management will worsen the underlying addiction. However, again, undertreated pain can lead to cravings, which can increase the risk of relapse. There are not a whole lot of literature, but there are a couple of studies of individuals maintained on methadone, MMT means methadone maintenance treatment, showing that opioid analgesia for acute pain did not increase their chances of relapse or recurrence of use. So keep in mind that individuals that you're treating for acute pain who already have an opioid use disorder and are already maybe on methadone, for example, already have that tolerance. So they may in fact require higher doses of opioids, such as the patient in our vignette, right? Risk of respiratory suppression similarly may be lower in patients who are opioid tolerant. And remember that opioid agonist treatment will treat baseline addiction, but not acute pain. So it will not address any acute pain. So therefore, we still need to treat the acute pain. So if the patient is on methadone and requires acute pain management, this is kind of the recommended approach. You continue the baseline methadone after verifying the dose from their home clinic. So every patient will have a home clinic where they go to on a daily basis. And I think it's recommended. And patients, as long as they're able to talk, able to communicate, will generally tell you what the home clinic is because they're worried about their not receiving their methadone, about having withdrawals. So once you get that, you call the clinic and verify the dose and continue it. If the dose cannot be verified, so for example, if the patient is admitted or comes to the ER later in the evening, the clinic is already closed. It may be safer to break up the self-reported dose in 3 to 4 times a day dosing rather than giving it all at once, right? Because that way you're reducing the risk of respiratory suppression. And on top of methadone, remember methadone is a full agonist, right? And doesn't have an amazingly strong binding affinity for the mu-opioid receptor. So you can still add in other short-acting opioids for breakthrough pain. Methadone for analgesia generally does require multiple times a day dosing, as opposed to when we use methadone for treatment of opioid use disorders, we generally do once a day dosing and can only be done through an opioid treatment program. So I think that's generally, again, you want to continue the methadone and augment with short-acting opioids. What about buprenorphine? Can be a little bit trickier, right, for acute pain management. You actually can, some of the recent data in the last few years have really shown that you really can continue buprenorphine through that acute pain management and if needed, augment with short-acting opioids. And additional short-acting opioids may still provide additional analgesia, even if the patient is on buprenorphine. And you can titrate up as needed. So sometimes for sort of post-surgically, in case of significant pain that requires additional opioids, that's often the strategy used now in 2020. Very often what we wind up doing is we split the buprenorphine dose in 3 to 4 times a day dosing and then augment with short-acting opioids. and titrate up as needed. Because again, much like methadone, when we're using buprenorphine for pain, we have to split it up into at least 3 to 4 times a day dosing to get sort of the most effect of it. So you can still add on short-acting opioids, of course, with caution, right? And I'm talking about acute pain here, not chronic pain, where of course the way we manage it is going to differ a lot. Many times, the standard strategy, so for example, I recently had a patient within the last 2 or 3 months was maintained on Suboxone, 12 milligrams a day, once a day, has been doing really well, but had a major dental procedure. Prior to the procedure, we talked to the dentist and we came up with a plan where following the procedure, we simply went up on her buprenorphine dose from 12 milligrams to 16 milligrams. So we went up by 33% and split it up into 4 milligrams QID dosing to give it more frequently. And in addition to that, we gave her some acetaminophen or Tylenol. And just doing that was sufficient for a couple of weeks. And once her pain management, once her pain returned to normal, we went back to our usual dosing. Sometimes in very significant pain, post-surgically specifically, it may be necessary to switch from buprenorphine to a full agonist, including methadone, and then augment with short-acting opioids. But that's not done too much. Of course, you want to, for mild to moderate pain, you want to maximize non-opioid medications. You want to consider things like epidurals, nerve blocks, etc., and consult a pain medication specialist, pain management specialist, if in doubt. What about naltrexone? Well, naltrexone is a mu-opioid blocker and a very powerful blocker. So acute pain management with naltrexone can be challenging to achieve because it also has a very slow speed of dissociation and a high binding affinity. So in general, I think it's a good practice. If you have a patient on naltrexone, encourage them to carry a card, a medication alert card that notifies first responders if needed that they are on this medication. In general, what we want to do is you're going to wind up using kind of non-opioid strategies, including regional analgesia, right? Multimodal analgesia, as well as non-opioid analgesics. I know, for example, at UNM for acute pain in individuals with naltrexone, they very often wind up turning to IV ketamine as a means of pain management. So I think that's often a strategy used. So this is just a little algorithm that I've included here in terms of how to handle acute pain management with methadone versus buprenorphine. So switching gears a little bit to chronic pain management here. So this here is again another art of someone done by someone who does deal with chronic pain and again I think is quite poignant. Some basic considerations. Again, the approach is going to be very different. When we were talking about acute pain management, I really talked about we have to treat acute pain, even in individuals with opioid use disorders, even if it means they need to be treated with additional opioids. For chronic pain, we generally take a much more cautious approach. One of the reasons for that is that here, when we talk about chronic pain, specifically chronic non-cancerous pain, a history of opioid use disorder is by far the single biggest predictor of aberrant behaviors to prescribed opioids, right? So consider right away, it's recommended that if you're treating an individual with chronic pain who also has a history of opioid use disorder, you may want to consider early consultation with a pain management specialist or with an addiction medicine or addiction psychiatry specialist. Use a multidisciplinary team approach. Maximize your non-opioid adjuvant medications such as NSAIDs, such as your serotonergic, noradrenergic reuptake inhibitors, such as your tricyclics, membrane stabilizing agents, and gabapentinoids, such as gabapentin and pregabalin, all of which for different pain conditions carry evidence. And also, don't forget about our non-pharmacological therapies. Many of them can be extremely effective. Think about CBT for pain, for example, or acceptance and commitment therapy, both of which are sort of psychological therapies that carry evidence bases in terms of chronic pain management. Think about things like mindfulness, right? Yoga, meditation, traditional healing, acupuncture, as well as interventions. And keep in mind also that at UNM, we do offer an entire echo clinic, the chronic pain echo clinic, Thursday afternoons at noon. So if you have a challenging patient, you're welcome to bring that patient to the clinic and do a consultation. Responsible opioid prescribing, right? There's some components to that. One is being aware of individual risk factors. using screening tools, ongoing monitoring for aberrant behaviors if you do prescribe opioids, as well as monitoring, including things like urine drug screens, PDMP, treatment agreements, and always naloxone co-prescribing. Really important to do, easy to do, and a very effective strategy. So I'm going to start here again with a vignette of methadone and chronic pain. With that introduction out of the way, a 64-year-old female who presented to the emergency department with dysuria and was found to actually have advanced cervical carcinoma with local metastasis. And a need for pain management was identified, but there was concern because she had a 30-year history of heroin addiction and concerned about injection drug use. So the treatment approach, again, it was felt, and this is based on a real patient that we treated with details, identifying details changed, of course, where it was felt that the pain management need was going to be so great for her pain that buprenorphine simply would not cut it. So therefore, she was started on methadone and was carefully titrated up. And that was done at the opioid treatment program to allow for that close monitoring, that daily dosing. And at the same time, she was placed on short-acting opioid for breakthrough pain by her oncologist. And there was, of course, close collaboration between the OTP physicians and oncologists. So in general, in some cases, the patient's opioid dependence may be better treated with methadone maintenance because it does avoid complications of possible precipitated withdrawal by buprenorphine, or more likely, difficulty obtaining effective analgesia if the pain management need is so great. By contrast, in many individuals with significant chronic pain and opioid use disorder, buprenorphine does a wonderful job of treating both. And this is a vignette of that. This is a 55-year-old female presenting for treatment for her addiction. She had a 12-year history of chronic pain following an ATV accident and a pelvic fracture. And she had gradually built up her dose of opioids up to 300 morphine milligram equivalents per day. And in addition, there were some concerning aberrant behaviors, such as buying off the street, running out early, and going to multiple doctors, right? And she was reporting problems in her marriage, work, relationships, right? And worsening depression and anxiety. So some things that were actually telling us that maybe she has also developed an opioid use disorder. And interestingly, she reported, I have pain everywhere and my pain is worse than ever. So it was also felt that with chronic opioid use, she had developed some degree of opioid-induced hyperalgesia, which is really this idea that when people are chronically on opioids, sometimes they develop a greater sensitivity to pain. And clinically, this is how they often come to you, that I have more pain than ever. Or I have patients who say, when I put on a shirt, my skin hurts, right? So what we did in that case is we started on buprenorphine and was built up to 4 milligrams 3 times a day. And actually the patient did quite well on it. She reported improvements in pain. She reported feeling happier, functioning better at work. And she said, quote, I have my life back. So simply by switching her to buprenorphine, we were able to address multiple concerns that the patient had, right? So some basic concepts. If chronic opioid analgesics are required for pain control, of course, buprenorphine may make it difficult to get analgesia from the full mu agonist. However, for many patients, here it says a subset of patients, but I would really say from my experience, for many patients with chronic pain and history of opioid use disorder or opioid abuse, right, which is the way it was phrased in this paper, you can get reduction of pain as well as mitigation of aberrant behaviors with treating them with buprenorphine naloxone medication. But keep in mind that for these patients, dividing into 3 or 4 times a day dosing may help with the pain more. And there is increasing evidence that buprenorphine may help mitigate this opioid-induced hyperalgesia, which is often a major clinical challenge for providers who are treating individuals with chronic pain. So going forward, this was a study, it's about 5 years old at this point. It's an interesting study. And what the study did was, it was done in a pain clinic out of California. And they took individuals with chronic pain who are on high doses of opioids, right? And here you can see the morphine milligram equivalents. So they started minimum of 200 morphine milligram equivalents per day. And some of them were well over 1,000 morphine milligram equivalents a day. And most of them were on multiple opioid medications, right, to get to that. And these were the patients who, despite these high doses and despite all the risks that comes with it, were still reporting quite a bit of pain. And the blue bar is their pain score on the visual analog scale, right? So 1 to 10, the higher the scale, the more the pain, right? And then what they did was they took all of these opioids and switched them over to buprenorphine monotherapy. So just to buprenorphine, which of course, as we've talked about in other presentations, is a lot safer. And then 3 months after that conversion, they evaluated their pain again. And you can see significant clinically as well as statistically improvement in their self-reported pain 3 months after they were switched to buprenorphine. And importantly, that happened even in individuals who were at sort of the highest doses of opioids. Those folks who were taking over 1,000 morphine milligram equivalents a day still got significant improvement in their pain, and they were certainly a lot safer. So important to keep in mind. The trick here with buprenorphine for chronic pain, so it's clearly effective, but the trick is FDA approval. The sublingual forms, which we commonly use for treatment of opioid use disorder, are not approved for treatment of chronic pain, but they can be effective and they can be commonly used, right? On the other hand, the buprenorphine patch, the Butrans patch, is approved for treatment of chronic pain, as along with the buccal form, which is the brand name is Bunavail. And again, I don't have any financial relationships, are both approved. But a lot of pain management physicians wind up using the sublingual forms because especially with the patch, the doses that are available in the United States are relatively low doses. And I've included just some guidelines about dosing the patch for reference. But if you're going to do that, if you're going to provide the sublingual buprenorphine for pain, it likely will require prior authorization from the patient's insurance. On the other hand, if you're going to use the sublingual form for co-occurring opioid use disorder as well as chronic pain, then if they're on Medicaid in the state of New Mexico, it will not require prior authorization, but it will require the provider to have her X number, right? So that's the tricky part. Finally, if someone has chronic pain, severe enough to require opioid analgesia, are not good candidates for treatment with naltrexone, because if they're receiving naltrexone, you're essentially taking away those opioid pain management options. So for those individuals, we really should think about buprenorphine and methadone as the appropriate options. It is 12:30, and I am going to end here. And I don't believe we have a case